This is another edition of Head On Shaw TV. I'm your host, Ian Holmes. Huge changes now in effect at Nanaimo Regional General Hospital. The Vancouver Island Health Authority says these changes to nursing positions will be of a benefit to patient care at NRGH, but the BC Nurses Union has huge concerns about the impact of a rising number of unlicensed care aides and how this really meshes into the healthcare system, healthcare outcomes. And we'll get right into it here with the BC Nurses Union. We have the Pacific Rim Chair of the Nurses Union, Joe Salkin, in studio. Also, Robin Maxwell, Project Director with the Care Delivery Model Redesign of the Vancouver Island Health Authority. Not comfortable coming in studio. Didn't want to get into a debate with the BC Nurses Union, but we do have some taped answers on these themes throughout the program, so we'll get reaction from Joe Salkin on what Robin Maxwell has to say. So the first question here for Robin Maxwell: what changes are being made to the staff composition at NRGH? Here is Robin Maxwell with VIHA.
So at Nanaimo, what we're doing is we're actually creating new teams of how our care providers are coming together to provide patient care. So in the past, we've had teams that consisted formally of registered nurses, LPNs in some of the units, and on some teams they've used healthcare assistants, but sort of in an ad hoc or as needed basis. What we're doing is actually formalizing the inclusion of the healthcare assistant within the nursing family on these 7 medical surgical rehab units at Nanaimo.
There is Robin Maxwell there with VIHA. And Joe Salkin, your reaction to that? Care aides in the past, not as much meshed into the system, now really formulated in working more hand in hand, it sounds like, with RNs and LPNs. What's your reaction to what Ms. Maxwell had to say?
Well, I think largely, in speaking with the nurses on the units, they would argue that the care aides have been in place for the last 1 to 2 years on most of the units, but they haven't had a formalized rotation where they were set in stone as part of the team and part of that already existing model. And so now what VIHA basically has done is in there saying that they're going to be freeing up the nurses to do the care that they were trained to do and bring in more care aides is what they're telling the public. What is actually happening, and I'll give you a good example so that you can understand clearly, a clear example on one of the units where on a night shift, they've taken 1 RN off of the unit and they've taken both of the LPNs off of the unit, leaving behind only 8 staff. And they've brought in more care aides. But what they did was they only brought in basically 1.5 care aides to what they already had. So they've lowered the number of staff on the unit, less hands to care for the same number of patients that they had in the past. And so the nurses would argue that it's not going to free them up to give them the patients better quality of care. It's actually going to make the quality of care much worse than what it is already.
And I'm hearing from VIHA and talking to Robin Maxwell at length the other day, saying that this is a response to an aging population, better serving the changing needs of people in our healthcare system, in the surgical units and transitional units. As you mentioned, that's what's being impacted here at NRGH. What's your reaction to that? A necessary change to the changing demographic we have here?
Well, basically, I would counter that with the fact that VIHA has also implemented programs to decrease the lengths of stay of patients who are coming in to have surgery or who are going through emergency and being admitted to medical units. And so that means that they have tried to keep their lengths of stay down, so they're discharging those patients sooner. So the patients who are left behind are the sickest of the sick. So it doesn't matter what age they are, they're still sick. And so now moving to more of a model where you're bringing in health care aides, which used to be called residential care aides because they worked in the long-term care facilities, and now you're bringing them in to work in an acute care setting, which they're not used to working in, and caring for extremely sick patients. And that's not the model of care that's good for any type of patient, not even our elderly.
Let's get a little more insight from the Vancouver Island Health Authority on why this care delivery model redesign is being implemented at NRGH. Once again, Robin Maxwell with VIHA.
This is something that's been going on for a number of years. Back when we did the observational studies, we discovered that the care that our patients were getting wasn't always exactly the way we wanted it. We found that patients weren't getting as much time with registered nurses as we wanted them to, and that activities such as care planning, patient teaching weren't always happening to the degree that we wanted to. So we engaged on a multi-year change project a couple of years ago to look at how was our care being delivered, what were the processes we had in place in order to ensure the patients and the families were always getting the utmost, the best type of care that they needed to and what they deserve to get from our hospitals. So we engaged in learning to communicate in new and different ways, to really utilize all of the education and the competencies of the entire interprofessional team. And this change is sort of the last step of that multi-year change, and that is to make the structural changes to the nursing family to ensure that we have the right providers providing the right care at the right time to meet those needs of patients. And those needs of patients have changed over the last 10 plus years as our population has aged, and also our ability to respond to meet those needs is changing because the population's aging. Our staff are starting to retire. We don't have the same access to professional staff like we've always had in the past. So we needed to learn how to provide the unique care of registered nurses with a body of registered nurses that are smaller than we've ever had in the past because our population is aging and starting to retire. So it's twofold. We've got increase on the demand side, but we also have a decrease on the supply side. And so we need to reconfigure our teams in order to be able to meet those needs in a new, different way.
There is Robin Maxwell talking about some staffing challenges, which is interesting because from the Vancouver Island Health Authority's perspective, saying that there's actually about 6 more nurses who are being brought into the fold here, but the nurses union saying effectively 24 full-time equivalent positions are being scrapped. So there's a bit of a differentiation there that I'm a little bit confused about. What's your reaction to what Robin had to say about that aspect of the implementation of the plan?
Well, we agree that they did start this process a couple of years ago, and they actually did involve the nurses in that beginning process in what they called learning collaboratives. And it was about communication and how they could build in efficiencies and those sorts of things. And a lot of the nurses who were involved in that process were actually really supportive. But when it came down to the crunch in the spring of this new change to the nursing family, that they call it, it left those nurses feeling like they had been duped. And that's their words. I've been duped, I've been lied to, they sold me a bill of goods. And because they were not ever aware that there would ever be a staffing and skill mix change to the way that we were supplying the care to our patients.
From Vancouver Island Health Authority's perspective, the changes at NRGH, Robin Maxwell again on the impact this will have on patient care and also health outcomes. Here is Robin Maxwell with the Vancouver Island Health Authority.
Change is hard. Change is always hard for anybody. And what we're asking all of the staff at NRGH to do, whether they're registered nurses or physiotherapists or healthcare assistants, is learn to work in a new and different way together. So that learning how to trust each other, how to ensure that we're making assignments that are appropriate, those are the types of changes that we're going through. But as we go through there, what it means for patients and families is they're going to have the right provider to provide the care that they need in the moment they need. So an example would be if a patient needs to actually assistance to get up to go to the bathroom, instead of ringing their call bell and it taking 5-10 minutes for a registered nurse to respond because they're probably doing a procedure on another patient or providing medications to a different patient or checking somebody back in from the recovery room, they'll have a healthcare aide who can actually respond in a more timely fashion meet those needs. It also means that when family members come to the hospital and they're asking, so what's happening with my husband? What is the plan for them? The registered nurse, because they've had the time to really engage in care planning and to connect with the physicians and to find out what are the barriers to discharge, what are the plan of cares that need to be put in place, they'll actually have answers to those types of questions that patients have, our families have. And we'll also have, patients should find that they're more prepared for discharge in an earlier and more sort of gentle fashion. What happens now is patients find out they're going to go home today and they get almost a bolus of information where everything comes and they tell you everything and then come on, get dressed, go home. Now we'll be able to do it slowly and more gradually over a couple of days because there'll be much more coordinated effort and happening. So patients actually should receive and expect better care, more seamless care, and enhanced communication, and that's what they'll see the difference on.
So essentially improved communications and a more efficient system is really the Coles Notes version of what Robin Maxwell had to say about how these changes will impact patient care and health outcomes. What's your reaction to what Robin had to say about that?
Well, I'd love to work in a unit that actually did what she's describing, but that's not the case. What we are saying will impact the patients is the fact that now a nurse is actually being given a load that's even higher than what they had before. So they're caring for more patients. So that means they're giving more medications, they're doing more assessments, all of those sorts of things that they had to do for less patients in the past. Even if they do bring in the care aides to do the washing, the bathing, toileting, somebody getting them up, you need to realize that when the nurses were actually doing those things, they were actually assessing the patients. They were teaching them how to get up and walk to the bathroom. They were assisting them in ways that the care aide won't ever be able to do, that the nurses will be able to. Impact to care, what you're going to see is you're going to see that the nurses are going to do what we call missed care. So there's going to be this failure to rescue. So if a nurse doesn't realize that a patient is decompensating or getting sicker, it's going to get missed because they're so stretched between any of the other patients doing all the other things administrative-wise that now they have to pick up with the discharge planning and those sorts of things. You're going to see medications are not going to be given on time, which is VIHA's own policies. You're going to see assessments of patients who are coming from surgeries not done in a timely fashion. You mentioned to me earlier when we were talking that you knew that VIHA was doing trials on all of the units, and the reports back that we are getting are substantiating everything that we have said would be an outcome for the patients. The patients aren't getting better care. They are getting suboptimal care, and that is the hugest concern for the patients at the end of the day. She talked about the fact that there was a shrinking workforce. Well, there's a whole pile of new grads out there. They hired 160 of them only. Last year they hired 270 of them. So where are those new grads going to find jobs? So I would argue that there's still a lot of people out there that would have taken those positions had they been offered, but that wasn't an option.
Our last question here, how will care delivery model redesign at NRGH? How will this new delivery system be monitored, and could adjustments be made? And for the last time, here is Robin Maxwell with VIHA.
Every day across Island Health, across all health authorities across BC and Canada, we're constantly monitoring the outcomes that our patients are receiving from the care we're giving. So we're constantly measuring length of stay, readmission rates, reason for readmission, infection control rates. So that will continue, just like it always has. We can measure that at unit level, at the hospital level, and at the health authority level. So we'll continue to do that. We're also able to know how much time we're spending in overtime, how much money, how often our staff are being called in on their days off to ask to work extra shifts. We'll be able to monitor overtime rates. We'll be able to look at, has our sick time of our staff gone up or down as a result of this change? And we'll also continue to ask our patients and their families, what was your experience like in our hospitals, through informal surveys that the unit staff give them on their day of discharge, as well as follow-up surveys that are mailed to the patients in their home through the Ministry of Health after discharge.
And there is Robin Maxwell. Got about a minute 20 left here for you to respond, Joe, on what Robin had to say about how will this be monitored and potential adjustments being made down the road.
Well, you know, and we recognize that they will be reporting all those things out to the Ministry of Health. That's part of their quarterly mandate that they have to do. One of the things that we would be asking for, though, is that the nurses actually get to see that data. That's the data that we've been asking for all the way along, that they haven't been giving to us, to show us the research on how this is going to be an improvement. And so we would like to see an evaluation process down the road as well and be part of that.
Thanks so much, Joe Salkin, the Pacific Rim Chair of the BC Nurses Union. I really appreciate you coming in studio. And also thanks to Robin Maxwell, Project Director with the Care Delivery Model Redesign for the Vancouver Island Health Authority. This will be very interesting to track this new system of delivery care at Nanaimo Regional General Hospital with the nurses, the RNs, LPNs, and also the care aides. And this is a story certainly that will evolve as it spreads to other hospitals around British Columbia. Up next, as I understand, Royal Jubilee Hospital and throughout the province of British Columbia. The Nurses Union, some very serious concerns here, as Joe Salkin underlined, and the Vancouver Island Health Authority thrusting ahead with this new style of healthcare in our hospitals. That's it for another edition of Head On Shaw TV. I'm Ian Holmes. Thanks so much for tuning in, and join me next time.